So I think this is one of the most important challenges in our field, because we have been able in the past decades to increase the outcome of patients with aplastic anemia. While I still pretend to be young, so I remember when I was studying aplastic anemia, and eventually the standard, the expected survival for this patient is close to 0%. So this was a kind of fatal disease, no way to rescue patient, but it was just thanks to the pioneers in the 70s, and most of these pioneers were the founders of the EBMT, that we were able to learn how to treat this patient either with allogeneic stem cell transplantation or immunosuppressive treatment. So from 0%, now we have specific studies showing that survival could be in the range of 90%, both for transplantation and immunosuppression. Actually, the data from the RAISE trial that we have presented in the plenary shown survival as high as 91% in patients receiving this triple therapy. On the other hand, we have experience with transplantation using some specific regimens like the FCC, showing that survival could be up to 90% for this patient. Of course, this is more relevant for young patients, because for patients older than 40, the outcome is not so good. And that was exactly one of the analyses that we are completing right now within our working party. And well, it's really fascinating. Actually, we have been able to analyze 3,500 transplants done for aplastic anemia in the past 10 years, between 2011 and 2020, and we confirm the impact of age on the outcome. Of course, age is not the only factor affecting the outcome. In addition to that, maybe the most important one was type of donor, as well as the year of treatment, because one good news for everybody is that we are still in our learning curve, which means that we are improving the outcome. So we had some alert in the past years, because the outcome of patients older than 40 is not so good. However, with this further analysis now, we have many good different messages. The first one is that we are improving, which is always good. And I think it's even more important that if we analyze data at the granular level, looking not only for age, but also for type of donor, we realize that for some specific transplant, namely transplant from matched sibling donor as well as matched unrelated donor, the outcome is not so bad, even for the age of 40 and above 40. We are in the range of a survival of 65 to 70%, so well, we can extrapolate some conclusion that basically are supporting our daily practice. We should offer transplantation, at least as second-line treatment, to all patients failing IST, despite they are older than 40, if they have a good donor, which means a matched sibling or unrelated donors. Of course, the outcome is not so brilliant when you move to different type of donors, mismatched unrelated donors, as well as haploidentical donors. So about the mismatched unrelated transplant, we are just publishing a paper in Blood. Juan Montoro was the principal investigator of this study. This study was also very well presented and received at the American Society of Hematology a few months ago. And eventually, we showed that the outcome is not as good as with matched unrelated donor. Nevertheless, it is not so bad. We know which are the factors that may affect the outcome, so we may work on those factors. Of course, we cannot change patient age. In most cases, we cannot change the donor, but we can play on the immunosuppressive regimens given in the context of the conditioning regimen. So that means that at least for some, I would say, not too old patient between 40 and 50, mismatched donor transplant is a very good option. Maybe for older patients this is not the best, but of course we have to keep working on that, eventually elaborating different strategies or better strategy to prevent the events that may affect survival, and I will go back to this in a second. Maybe if we look to for transplant from haploidentical donors, the situation is different, because honestly for patients older than 40, the outcome is not very good. Of course, we are at the beginning of our learning curve with haploidentical donors. We use a conditioning regimen that has been developed by our colleagues and friend Amy Dezer at Johns Hopkins University in Baltimore. Well, I think this is very good for young patients, but still not optimal for older patients. So maybe this is something that we can not offer systematically. We have to think about maybe looking for a mismatch. I mean, we don't know. We have to collect proper data, and we need higher number, making sure that we have the right evidence for driving treatment decisions. I was alluding to the fact of the complication, and this is also important for patients receiving immunosuppressive treatment, because most of the patients with aplastic anemia eventually die because of infectious complication. So in the concept of transplantation, this may be also associated with GvHD, especially chronic GvHD. Nevertheless, if we are able to keep the rate of GvHD lower, we may also improve the rate of infectious complication. So putting everything together, while we are learning, we are still working a lot, and there is a lot of work ahead. I'm very proud that with the EBMT we are discussing a very interesting study that we can do in the near future, just trying to have a kind of a prospective, non-interventional study looking both at patients receiving IST or transplantation as initial treatment. This is very important, because this is exactly what we need to draw the treatment decisions.